Hello and welcome to this video that we are completing in response to a piece of work we did analysing the things on social media that patients with IgA nephropathy wanted to know about. This is going to be hopefully a fun video because it's all about what doctors say and what doctors mean and why we use the certain language that we use and how we could be clearer, because one of the common themes from the analysis was that doctors often aren't very clear in what they say. And we use perhaps a coded language that can be difficult to understand. So I'm delighted that we've got John Barrett here with me, and we're going to, well, largely apologise actually for some of the language you've used over the years, and perhaps outline a better way of talking to patients and explaining some of the terminology that we use. Okay, so John, one of the this is hard for us to admit, but one of the common themes we found when we analysed the social media data was that it did not necessarily reflect the patient-doctor interaction and communication in a way that we would be proud of. And actually, patients were very frustrated by some of the terminology that healthcare professionals used when they were talking to them, and the way they ended conversations and things as well. So I thought we might do this as a way of atoning for our previous sins and for future sins probably, and the sins of our colleagues. So what I'm going to do is I'm going to go through some of the things that patients have picked out that we say in consultations that don't mean much to them. We'll admit when we've said these things, and then we'll try and explain what we really mean and how we can do better.
Right.
Okay, so first one. Why do we say kidney function? What does kidney function mean?
So, as you and I know, kidney function means lots of things to lots of different people. What I think we're trying to get across is how much functioning kidney, how much, compared to what we started with when we were well, how much kidney function is left as a kind of aggregate of how the kidney does all of the jobs that it does. It is a very nebulous term. And I've always tried to explain it in a way that you start with 100% of kidney function, and as your kidneys deteriorate, that percentage of function gets less and less and less. And I hold my hands up, it's a term I use virtually every single consultation. And perhaps, and I should check with the person sat opposite me what they understand when I say kidney function. Yeah. Because I go in mentioning it all the time, and they come out thinking their kidney function is something that perhaps it isn't. And so it's a very difficult thing to get across in terms of how we are talking about kidneys to the patient. But I think it's the best way I can describe it is trying to say how much of that overall function you have at that particular point in time, and then relating to how that has changed over time and what things might look like in the future.
Yeah, I mean, patients, I think, from the analysis, seem to associate kidney function with their kidney percentage. And I know I do this in clinic as well. I'll take the EGFR, the estimated glomerular filtration rate, which is an estimation of how much the kidneys are filtering, which, as you say, might start up at around 100%. And then we turn the number into a percentage. So we'll say your kidney function percentage is 30%. And that can be quite alarming, actually, if you say that in those terms. God, I've only got 30% of function in my kidneys. So maybe being a bit more subtle and understanding in the parlance and the way we express that would be helpful to patients.
I think, and also it's really important to understand these things change. And giving the patient with kidney disease an understanding of how quickly their kidney function is changing. Having a kidney function of 30% is clearly not normal, but if it's going to stay at 30% for the next 20 years, that's less of an issue than if it's 30% and there's been a slow decline, because that will help us understand what might happen in the future. Yeah. And something, certainly a patient view, which a lot of patients have access to, and I would recommend if you don't have access to patient view, please get access to Patient View if you're here in the UK. It is a fantastic resource that allows you to access your blood results and gives explanations for each of the blood tests that you've had done. And there it allows you to look at the change of your kidney function, your GFR, over time. And that's certainly something I do as a doctor, so that I can help prepare my patients if their kidney function is slowly getting worse, so I can give them an estimate of when it might be that they might need a kidney transplant or they might need to start dialysis.
Absolutely. I'm glad you brought up patient view as well, because there are a lot of numbers that go on there. And one of the other questions, which again, as a doctor, I'm embarrassed about really, was there are lots of people asking what the relationship was between creatinine and estimated glomerular filtration rate, EGFR. And for you and I, that's a very straightforward relationship. But if we're not explaining that to patients, that's a bit embarrassing really, isn't it?
No, it is. People ask what their creatinine's doing, and they ask what their GFR is doing. And what we need to be able to explain to patients is that we take the blood test creatinine, which is measured on the blood test the patient has done every clinic, and we perform a mathematical calculation on that blood result to generate the EGFR number. Yeah. And so what that means is as your creatinine goes up, your GFR goes down. So a lower GFR means less percentage kidney function. And when that happens, your creatinine level is higher. And you're absolutely right. We look at those things and we make automatic assumptions, and the patients are trying to, if they have the confidence to ask, they're trying to play catch up and trying to understand. And that's something I would recommend to all patients. If you don't understand the result of a blood test, ask your kidney doctor. Absolutely. It won't be that the kidney doctor doesn't want to tell you. It's just perhaps they are not concentrating on explaining everything to you because other things are going on in the consultation. And I can't imagine a kidney doctor would not want to be happy to explain what a particular blood result meant.
Okay, thanks, John. That's great. I think we can both admit that we've erred when it comes to describing creatinine, EGFR, and kidney function. So the next thing that came up through the analysis was that there's a bit of confusion around the terms to do with urine protein leaking. So sometimes patients have been told they've got protein spillage or protein leaking, or they've been told what their PCR is or their ACR. And these terms really don't mean a lot to patients initially until they read a lot about them. So I know I have just said, oh, your PCR is better, that's great, and not really stopped to check whether that's something that means something to patients. Maybe you're the same, I don't know.
Oh, most definitely.
So how do you think we can do better here, John?
Well, I think first of all, it's important for patients to understand what protein in the urine means. So the kidneys are a very well-developed organ that in normal circumstances, very little protein at all gets into the urine. And so if we try and measure the protein in the urine, and we can do that in a number of different ways. We can measure protein in the urine by using a dipstick. So you'll often see the nurses take urine away at the time of a clinic. They'll go into a back room and they'll essentially put a dipstick into the urine and there'll be a colour change on the strip. That's the simplest way of looking for urine. The more complicated ways are actually taking that urine sample to the laboratory and doing a chemical test to measure the absolute concentration of protein in the urine. And why kidney doctors are so obsessed with protein in the urine are for two reasons. The first is if you have protein in the urine, it's a sign that you could have significant kidney disease. So it's a sign that we look for that then will precipitate a whole series of other tests to try and understand why the protein is in the urine. The next thing is that if you have kidney disease, the amount of protein in your urine is a risk factor for you developing progressive kidney damage. So it's not only a marker of kidney disease, but it also tells us the likelihood of you potentially developing progressive kidney damage and needing dialysis in the future. And that's why we look at protein levels in the urine at every clinic. Mm-hmm. And so we've got a way of checking the urine with a dipstick, a nice and cheap way of screening urines. And then we have a variety of ways of measuring the amount of urine. So for most patients, they bring a urine sample along to clinic, and what's measured on that is a protein or albumin concentration. So protein is everything in the urine that's a protein. Albumin is just one particular type of protein. And different kidney units measure either one or the other or both. And what we do, so that's the A or the P in ACR or PCR. The CR is the creatinine. And we've talked about what creatinine means in the blood, but creatinine also gets into the urine. And what we use the creatinine for is to look at how concentrated the urine is. So if it's a hot day, you're going to produce a very concentrated urine and the creatinine level will be very high. If you've just had lots and lots and lots of fluid to drink, you'll produce a dilute urine and the creatinine concentration will be very low. And we correct the protein to the creatinine to correct for whether you're producing a concentrated urine or a dilute urine. And therefore we get either an albumin to creatinine ratio or a protein to creatinine ratio. And that gives us a measure of how much protein or albumin is appearing in the urine at any one time.
Absolutely, and it's a really, really important and sensitive marker of disease activity as well. So once you present with IgA nephropathy, if you have levels of protein in your urine that are raised, and we start you on treatment, or you're started on treatment for that, one of the ways we'll measure how you've responded to that is to see what happens to those levels of protein in your urine. So we all get very happy if those levels go down, and if they don't, that's when we start to talk about other things that we might need to do.
No, absolutely. And some of patients may actually have been asked to collect the urine for a full 24 hours, because the most precise way to measure how much protein or albumin is leaking from the kidney is to get a big container, take it home with you, and then every drop of urine you produce over a full day goes into that container, and then we measure the protein that's come out in the full day. And for those patients in clinical trials, that's a standard way that we measure protein leak from the kidneys.
Thanks, John. That was great, and I hope that's really clear. And if it wasn't clear, of course, people can always go back and watch that section again and clarify anything with healthcare workers if they want to. So the next 3 bits I'm going to ask you to comment on are the syndromes. That in itself isn't a very accessible term, is it? That we use as kidney doctors and health professionals, and those are that describe the characteristics of a given patient at a given time with any disease. And those are chronic kidney disease, acute kidney injury, and end-stage kidney disease. And one of the repeated themes on our social media analysis was, what's the difference between CKD and IgA nephropathy, or can I have IgA nephropathy and CKD?
Okay, so Matt, as we both know, we use these terms in the middle of sentences without even thinking about it. And as doctors, we love to shorten them to AKI, CKD, and ESRD or ESKD. So AKI is essentially a syndrome where the kidneys stop working very, very quickly. And there are many, many different causes. IgA nephropathy very rarely causes AKI or acute kidney injury. But you can have acute kidney injury with IgA nephropathy. But it's just where the kidneys fail very, very quickly. And that's over a period of weeks to months. CKD, or chronic kidney disease, is where the kidneys fail but very slowly, and where there's clear evidence of kidney damage and scarring. And that's evident either by the presence of protein in the urine, an altered blood test, or an alteration to how the kidneys look in terms of how they're imaged. So whether they have, for instance, a disease called polycystic kidney disease. IgA nephropathy is just one of very many different causes of CKD. So most patients who attend the kidney clinic with IgA nephropathy have by definition CKD as well. It's not a different disease, it's just a different way of describing the kidney disease. And then ESRD or ESKD, end-stage renal disease or end-stage kidney disease, is defined as that point in time where your kidneys have stopped working altogether and you require some form of therapy, be that a dialysis therapy or be that transplantation.
Excellent. Thanks, John. I think that's very clear. So moving on, IgA nephropathy is the condition that we're talking about, but a number of patients who'll be watching this will have been told when they're younger that they have a condition called HSP, or Henoch-Schönlein purpura. And there is a fair bit of confusion around whether HSP is the same as IgA nephropathy, or whether HSP even exists as a term anymore.
So again, that's something that I get a lot of questions about. And so the first thing to say is Henoch-Schönlein purpura, or HSP, is now called IgA vasculitis, just to complicate matters a little bit more. But people can call it HSP if they like. In terms of the differences between HSP and IgA nephropathy, HSP is a disease that affects other organs apart from the kidneys. So it affects the joints, it can affect the skin with a rash, and it can affect the bowel, and it can cause tummy pain and bleeding into the bowel. Whereas IgA nephropathy just affects the kidneys. And quite often what people find is they may have had the rash as a child or as a young adult with no sign of kidney involvement, and then sometime later someone realizes they've got blood and protein in the urine, they have a kidney biopsy, and they've got IgA deposits in the kidney. Now, when we look at a kidney biopsy, what we will see is IgA deposits, whether it's IgA vasculitis related or IgA nephropathy related. We simply cannot tell under the microscope one from the other. And so it's very difficult really to tease out whether you had the rash and IgA vasculitis or HSP as a child and now you've developed a different disease, or whether it was the same disease, it just took a little bit of a time for the kidney disease to develop. And actually there's a lot of research going on at the moment to really try and understand whether the two diseases are the same disease that just present in different ways, or whether there are some very fundamental differences that might mean that we need to diagnose them slightly differently and treat them slightly differently. But at the moment, we think that they are related, but we're not quite sure how.
That's great, John. Thank you very much. And I've learned something there as well, so that's always handy. I'll put that on my continued professional development. So we're just going to move, so some of these terms I'm going to ask you now are slightly more generic. These perhaps not related so much to IgA nephropathy, but certainly we do we use these terms a lot as doctors or as healthcare professionals. So if you could give me a quick answer as to what we mean by these things. So when I say edema, what do I mean?
So edema just means there's too much salt and water in the body and you have swelling, often of the legs.
It's a very common symptom for patients with kidney disease and patients with IgA nephropathy. When your doctor says hypertension, what do they mean?
It's another word for high blood pressure.
Good. If I'm in hospital and I'm told my saturations or my SATs are low, what am I being told?
So this will be measured usually with a probe on the finger or on the ear, and it's looking at the percentage of oxygen that is attached to the red blood cells that are circulating around your body.
And if you're in hospital, you'll have it done at least 4 or 5 times a day.
You will.
It's a term you should learn to, not learn, you will grow to understand, hopefully. Again, this is usually if I'm in hospital. I've been told I'm tachycardic. What are my doctors trying to tell me?
So that means your heart is racing and your pulse rate is elevated.
Okay. A disease-related term now. So when my doctor tells me I've got high levels of inflammation, what are they on about?
So if they're relating that to a blood test, there are a number of different things we measure in the blood that are elevated when there is inflammation of any part of the body. And the things they will be looking at will be something called a CRP, or C-reactive protein, and the white cell, the infection-fighting cells in your body. So they will look at those two, and if they're both elevated, they'll say there's either infection or inflammation.
That's a really nice explanation. But the other side of the coin is sometimes kidney doctors in clinic will tell me that there's inflammation going on in my kidney. So what does that mean?
So often that will be in the context of having had a kidney biopsy and actually being able to see firsthand that there is inflammation in the kidney. And by that, they will see an accumulation of cells within the kidney that we know are related to inflammation. So they are essentially reacting against the processes within the kidney to cause damage to the kidney. Often they're fighting, the cells are damaging your own tissue because there's an error in the immune system.
And that's a really important point to just bring it all back to, is IgA nephropathy at its heart is to do with dysregulation of the immune system. And one of the ways it does cause damage in the kidney is that you get these repeated bouts of inflammation within the kidney.
That's right, and it may or may not be obvious to you as an individual, but there is inflammation going on, and that's what we see when we look down the microscope, when we look at a kidney biopsy.
Thank you very much for all of that. So again, I will openly admit I have said all of those terms and not checked that patients have understood what I've meant. So I am sorry. I'm just going to finish off now by saying one of the things that annoyed patients the most through the analysis of social media was the feeling that they were having their symptoms dismissed, but also towards the end of consultations, there was a bit of a rush to make sure everything was done. And there were a few phrases that patients highlighted themselves that they got annoyed by that I think we should just own up to and acknowledge and try not to say again. And one of the things patients didn't like being told was that they don't need to worry about that now. And that might be in relation to what might happen if I need a transplant or what might happen if I need to go on to dialysis. And us as the healthcare providers have said, oh, well, your kidney function is okay at the moment, so we don't need to discuss that now. But I suppose if a patient is telling you that in clinic or asking that in clinic, yes, it might not be the best time to talk about that, but we certainly need to do better at least acknowledging that that's an important part of the patient agenda and not just dismissing it in that way.
No, I agree. And that if we're going to make a statement like that, we need to be able to explain why we're thinking that. We need to verbalise our thought processes. And if that means showing them what's happening to their kidney function, their GFR, and showing how it's not changing and how that will predict what might happen in the future, then we need to be able to explain it in a way the patient understands and to a level that they want to know. And some patients want to know in more detail than others, and they need it in different ways. Some people may respond to seeing a graph, others may respond to seeing numbers. We need to find out from the individual patient how they want that information given to them.
Absolutely. And the other pet peeve I'm just going to mention that came up repeatedly was finishing an explanation as a healthcare provider with the phrase, do you understand? And that can be, I suppose, quite intimidating actually, because what if I don't understand? Is that my fault? Am I stupid for not understanding?
No, that's very true, Matt. And I think what we need to be asking is rather, do you understand, as almost a question that we expect the answer to be yes, to, is there anything else you'd like to know? Is there anything you'd like me to go over again? Because I think if patients understand what is going to happen to them, understand what is going on at this very moment in time, they're more likely to be able to take control of the situation themselves, feel empowered to manage their blood pressure, alter their lifestyle, take their medications if they understand why those medications have been prescribed. So it's beholden on us to really ensure that our patients understand what we want to achieve for them and work in partnership with them.
I saw a nice thing written on Twitter the other day, and rather than finishing with do you understand, why not finish with what is it today that hasn't been as clear as it could have been, or something like that.
No,
inviting.
Yeah, absolutely.
Okay, thanks, John. That's really good. And I think we should just finish by saying, actually, the whole way we need to correspond with patients now needs to be fit for the 21st century. Historically, when a patient came to clinic, a doctor or a healthcare provider would write their letter about the patient back to the GP with a copy of that letter sent to the patient. And that just led to all sorts of the types of language and medical jargon that we've been discussing here being written in these letters. And that's not really an accessible way of patients to have their consultations summarised. So actually the Academy of Medical Royal Colleges now recommend that all interactions with patients, when there's a corresponding letter afterwards, should be addressed and written to and for the patient that it's about, with a copy sent to the GP. And that just makes perfect sense, doesn't it? Because you're now going to be writing things in a style perhaps that is more understandable, and actually it's putting patients back at the centre of their care.
No, I completely agree, Matt. And one of the things I say to my patients at the end of a consultation, because often we do cover quite a lot of ground, is I reassure them they're going to receive a letter that's going to summarise what we've discussed. And I tell them that if they have any questions or they don't understand anything, write on the letter, jot down some notes that they want to pick up with me next time. Or if they're very worried about a phrase that they don't quite understand, or they think they've misheard or misrepresented something in the letter, then they can get in touch with me and we can clarify things very quickly.
Well, thank you very much, John. Well, there you go. I hope that's been useful, and I hope we've managed to debunk some of the medical jargon that's commonly used in and around patients with IgA nephropathy. And I hope we've apologised enough for our previous sins, and we apologise on behalf of our colleagues as well. I'm certain we won't be perfect from here on, but we will try to do better, I promise. If you'd like to know more information about the things that patients with IgA nephropathy wanted to know about, there's a series of related videos that you can access below. And if you would like to know more about writing to patients directly and improved patient-doctor communication, then have a look on the Academy of Medical Royal College's website. So thank you very much from me, and
thank you, and goodbye.